Hi, everyone. Welcome to Haag-Streit webinar, Clinical Confidence with a Lenstar, featuring keynote speaker, Dr. Elizabeth Yu. I'm Genevieve Fay, Senior Market Director at Haag-Streit. Some quick housekeeping notes before I introduce our featured speaker. Just so you know, for questions, the questions will all be taken at the end. So please use the Q&A button, not the chat. And you can load questions in as you get them or as you have questions. They will be answered at the end. And again, please use Q&A and not the chat button. And then lastly, please do know that this is being recorded. Now introduce our speaker. Dr. Elizabeth Yu earned her medical degree at University of Florida College of Medicine and did her residency at Rush University Medical Center in Chicago. She served there as chief resident during her time there and then followed with her fellowship at Baylor College of Medicine, doing a fellowship in cornea, anterior segment, and refractive surgery, where she also served as assistant professor after her fellowship training. Dr. Yu joined Virginia Eye Consultants in Norfolk, Virginia in 2013, becoming a partner in 2014. She continues her commitment to residency and training in ophthalmology as an assistant professor at the Eastern Virginia Medical School. And she is the medical director of the Virginia Surgery Center, sitting on the board also of board of directors at the Virginia Eye Foundation. Dr. Yu provides guidance and governance across several national medical boards and committees, including as an examiner of the American Board of Ophthalmology, current advisor of ASCRS Young Eye Surgeons Clinical Committee, and also as the chair of the cataract section of Ophthalmic News and Education Network for the AAO. She has authored numerous articles and is a frequent lecturer nationally and internationally in the areas of refractive cataract surgery, anterior segment reconstruction, ocular surface disease management, and surgical management of astigmatism. Editor-in-chief of U.S. Ophthalmic Review, she is also the medical editor of the digital journal Millennial Eye, and she's been recognized with many, many awards and on Powerless. With that, I would like to introduce to you Dr. Elizabeth Yu.
Thank you so much. Good evening to everybody. Thank you so much for taking time to join today. My name is Elizabeth Yu. Let me just go ahead and share my screen. We're going to go on just a little bit of a journey with regards to refractive cataract surgery. I want to make sure you do see my screen. Really, this is about gaining a little more clinical confidence with refractive cataract surgery in general. And I wanted to help provide pearls there and an overview there, and how, for me, my major experience has been utilizing the Lenstar 900 capabilities and just recognizing that it is not just a bionic biometer. So for me, I have primarily used the Lenstar 900 since 2007, I suppose, when I entered fellowship training at Baylor Cullen Eye Institute. And that has been my primary optical biometer. And I've just gained more and more confidence with its capabilities and recognize that it is an excellent keratometer. And it really helps with accuracy, both with magnitude, with astigmatism and delta, with the meridian and the amount. And so let's see how we incorporate it in becoming just more confident with refractive cataract surgery and just the process. So it's so important as a refractive cataract surgeon, obviously, just holistically, that we standardize and optimize that cataract evaluation process, because the moment that the patient walks in is how they're going to gain their first impression. And so creating that level of confidence that from the moment they meet the front desk staff, to the technician, to the education process, whether the technician is the surgical counselor, is the person who is going to be the cataract education counselor, or if it's a bigger practice and it's split up, whatever it is, it just needs to be somewhat of a standardized process. So the patient also senses that there is a cohesive process and handoff throughout, and keeping concepts simple, and the surgeon can then provide that chair time and experience. Because I don't know about you, whereas before it used to be maybe 1 in 25 patients who was a post LASIK eye or post RK eye or a post, I haven't had surgery, but my neighbor or my family, my brother, my so-and-so. And that conversation took a little longer. Now it's 1 in every 5 to 7 patients who is said eye or has that said experience or has been to Dr. Google or Dr. Facebook, right? So it's so important that because patients are coming in with a formulated opinion, we know that having that kind of standardization and giving that preconceived quality, it will also help us then give the patient greater confidence in the skill set of what we'll be able to do. And it helps us assess patient personality and set realistic expectations using simple terms, using analogies. So for astigmatism, we can do the football egg round basketball. Sure, I don't necessarily will do that. I'll functionally say astigmatism is like when you're in focus or out of focus, standard definition versus high definition television. If you want to be able to, without glasses, look in the distance and determine the C versus the G versus the O without squinting, is that a 3 or an 8 without squinting? That's what fixing astigmatism will afford you. So that helps them. Oh, I understand. And you can see that, especially with patients who have not had Botox, and you can see that frown line or whatnot, or the patient who's crunching numbers at the computer all the time, and they wish to have that level of accuracy and refined vision up close. These are the things that you want to be able to help describe to them with a little more clarity when we're at that patient conversation and setting those expectations. Number 2, we want to get to know our patient. And I always like to say, we want to say more than hi and understand the I. So meaning get to know them a little bit deeper, but also understand the eye's comorbidities as well as prior surgeries. Know if they've done monovision, if they were successful with monovision contact lenses, any ocular comorbidities, their profession. How important is it to understand if they're going to retire, their near vision needs, and how many hours a day are they at their computer? For me, I always get a myography because so many of these patients are new coming into our practice. And that myography is the one test that really gives me a snapshot in time to assess the chronicity of any potential dry eye disease, specifically evaporative dry eye disease, that is associated with one of the biggest risk factors, which is MGD. And so it helps me gather that information, because if they have more than 20% atrophy, presbyopia correcting lenses, not an option, period, because their reserve is already below baseline. So I know that anything else I do, whether that's surgery, then topical drops, their evaporative dry eye will get worse. And I recognize that looking through my own patient charts at dissatisfaction before, that they had MG atrophy. And so now that is a very important component of what I do. And I look at lifestyle considerations. For example, so somebody who has had prior myopic LASIK, it doesn't rule them out for necessarily presbyopia correcting lenses, but looking at the quality, especially at that axial curvature map, right? So on a topography, the axial curvature is going to look perpendicularly at the way the ray perpendicularly of light hits the corneal curvature against their optical visual access. So I want to look at that regularity. So looking at the right eye versus the left eye, so the left side versus the right side, you can see a clear delineation between the regularity of the astigmatism and the higher order aberrations. This is someone where I could consider a presbyopia correcting option, or even a zero sphericity monofocal versus someone who I would absolutely not consider a diffractive IOL-4. Pearl number 3, long-term vision requires eyelid and ocular surface disease management before any surgery is performed, because cataract surgery is a one-stop, one-time correction of vision. But true vision, the long-term consideration of vision started well before they entered that exam chair, and is going to lead to and requires long-term, years after, hopefully, they finish cataract surgery. But that means that we have to think about that. So we need to also recognize that we need to identify, and this is why it's also in this obnoxious color, because I want us to remember something that Eric Donenfeld says so eloquently: treating lid and ocular surface disease and recognizing and discussing it with the patient is setting a patient expectation. But identifying it or talking to the patient about it after surgery is a surgeon's complication, even though it always existed before. This is an example of my patient after one set of numbing drops and dilation drops. One set shows, where their preoperative corneal topography maps, keratometry values, they were all consistent, very smooth Myers. One set alone did this. So it shows you this is a patient where I absolutely know that this is someone where if I did anything to them, could definitely, from a diffractive IOL, the surface would not tolerate it very well. They're high risk. And it's because they already have some level of either exposure, they're not blinking, and they have evaporative dry eye disease, and their surface is already vulnerable. So this is a consideration. Cataract surgery incidence can be up to a third of patients that occurs beyond 3 months after surgery. That's really important to consider. And one of the biggest risk factors for postoperative disease is preoperative disease with MGD, whether or not there's abnormalities within the architecture is one of the bigger risk factors. Again, a reason why I do look for it, because that is one of the target causes. And it makes sense because MGD is one of the biggest risk factors and associated causes of dry eye, period, and a majority source of dry eye in our patients. With that being true, looking at that instability, that makes a lot of sense to us. If 1/3 of our patients can have persistent dry eye or worse disease after surgery beyond 3 months, this is something that I think about all the time. So I have to identify and try to treat, and also be very mindful about why I'm bucketing who I would consider any presbyopia correcting options. And that's considering any, including refractive EDOF lenses, such as the Vivity lens, because while it is definitely more forgiving, it is still splitting light somewhat, and there is still contrast sensitivity concerns. So this is where I will hedge my bets, and I will lean towards definitely going with an enhanced monofocal, where I know that there is not that splitting of light and patients can have a much more favorable outcome for the long run. Because you can aggressively treat their dry eye in the short term, but patients, unless They're going to be willing to have a social contract with you and manage that dry eye aggressively long term. Most patients don't want to do that. And they're shocked that, that they have to keep up with it, and they don't want to keep up with it. And that's part of that conversation piece. So there are different diagnostic algorithms. I pick and choose different pieces and I do read them. I do think that the ASCRS Cornea Clinical Committee provides a very nice algorithm to show the different sources of etiology, but to help in the setting of cataract and refractive surgery. And this is definitely an example of, on every patient, not only am I for cataract surgery, I not only get a meibography, but I only at the inferior lid margin, because we only have so much time, I always compress the central inferior lid margin for 5 full seconds. And I look at the telangiectasis. So I'll measure the quality, so M0 through 4, 0 being the olive oil. I also will grade expressibility, easy to difficult, and telangiectasis to see how inflamed they are. So 0 through 3 being diffuse, being very inflamed. And those are, and I'll measure that component. But MGD, besides looking at primary inflammation and MGD sources like rosacea, is an obstructive disease. The lack of blinking or the lack of full blinking, because we're staring at the computer or contact lens use, the lack of full blinking causes the meibum to not egress. So not egressing leads to pressure and buildup of the meibum. That leads to pressurization and pressure atrophy and destruction of MGD. So it's not an inflammation-driven disease. It's not a primary inflammation, but it is a pressure mechanism, which is why the lid blinking exercises and such are so important. And to that point, this patient here had a history of Bell's palsy on the left side in the past. And I noticed that on the right, she actually had a few more wrinkles when she would lift. The left was smoother and it's subtle, but you can see her squeeze is not quite as strong on the left. But look at this. This is what is so unique. This was a patient younger in her 30s who was coming in for a LASIK evaluation. And I noticed that how interesting is that her meibomian gland architecture shows how much more truncation and atrophy there is on the left, really speaking to the point that a weaker lid blink is what is leading to the fact that there is going to be the pressure atrophy because the meibum doesn't express and the dropout. So it shows you that MGD is truly not inflammation driven, but inflammation is a secondary process, unlike aqueous deficient dry eye disease or Sjogren's, for example, with the lacrimal gland. So if you look at, the anterior lid margin, blepharitis is definitely, we're becoming much more aware to look at the anterior lid margin, and the majority source there is due to Demodex, and there are 2 forms for which folliculorum lives in the actual lash follicles because it's so rich in oil there, and brevis lives in the meibomian glands. Unless you have the patients look down, we're going to very commonly miss the cylindrical dandruff or the actual collarettes that are there. And, I'm not going to go into all the various treatment options, but look for these lid and ocular surface diseases. Manage these on the front end. And certainly I'll give you my email address at the end, and email me if you want to see how I acutely and chronically manage some of these patients, because for some of these diseases, there aren't RX therapeutics, so at least to kind of prep our patients for cataract surgery. So pearl number 4, so important. OSD is much more than just dry eye disease, which is tear film imbalance. There's ABMD, Saltzman's nodular degeneration, and certainly pterygia too. And we know if the pterygia grows more than 1 millimeter onto the corneal surface, that affects our measurements. And it's so important. It will lead to false or induced astigmatism. And that needs to be identified and differentiated from true corneal anterior astigmatism. The Placido image, which we can find on the Placido topographer, which is part of either the Lenstar topographer or other Placido topographers. That Placido image is so important, and you have to have that to assess the quality of your astigmatism. Nothing else will give you true quality of the astigmatism, right? So looking at that Placido image and the axial maps really give you the sense of the quality of that astigmatism. Is it regular versus irregular? You can see here that these are not sharp bullseye images. And then to the right, another thing you can see here, and I've said it before, looking at the average delta K values, it should be pretty similar between the two eyes. And here the power is 42.7 in the right eye and 41.06 in the left eye. That's not common. So that should alert you to the fact that something is going on. And look at this after dry eye disease treatment, same patient, 6 weeks later. Look, while not perfect, but look how sharp these images are. Round bullseye, because this is reflective data. Look how much better this right eye, the upper image, no more red spots and blue spots on the axial map, right? And the Myers, but the power map, the delta K, the average corneal curvature. So the Placido ring images capture around the 3.2, around 3.2. That's where it's reading. And everything else is interpolated from there. So it's not the most central data, but it's around the 3 millimeter zone, but 42.2 and 43.55, that I can trust. I want to see no more than about 0.25 to 0.3 diopters difference between naive corneas, between two eyes. And certainly this gives me much more confidence. Look at this, inferior steepening, right? Here at first glance, I would think keratoconus, but again, you need to compare it to the Placido image. Here, it tells you, if this were a stromal disease and thinning disorder, the Placido image should look normal, right? They'll be closer together because it's steep, but it shouldn't be smeared. The smearing shows you there's something going on at the epithelial layer, and certainly it's EBMD. And this is the same patient after superficial keratectomy. So everything needs to be based off of, you see that there is something pathologic, but you have to have a clinical correlation at the slit lamp examination. That was truly a patient sent to me for a keratoconus evaluation. Now, again, same thing. Corneal stromal scar, you can see that it would throw you off to think that's the real pathology. And you would miss that, if you have subtle ABMD, that sodium fluorescein staining, which I found that there was a subtle irregularity that didn't fit what I was seeing on the clinical image, clinical slit lamp, that it was the negative staining because of the elevation from the ABMD and the Placido imaging on the actual topography that led me to find the ABMD. And that, because it's within the 6 millimeter zone, that's going to be very important to consider for cataract surgery, because that would definitely affect your results on your astigmatism. And Saltzman's, even though this is peripheral, please do not take what you find on your topography, keratometry values, and fix the astigmatism based on that information, because that reflective keratometric topographic astigmatism value is induced astigmatism, not the refractive astigmatism that the patient is actually seeing or has. And so this needs to be addressed if you're trying to give the patient freedom, or else they will have a missed outcome. They will have a refractive miss after surgery. So this needs to be addressed. You need to wait 4 to 8 weeks have interval topographies and measurements and make sure that it's stabilized. Generally, it's about 6 weeks for full healing, and then repeat the imaging 2 weeks later. But certainly it will change the values quite dramatically after the patient is healed. And that's the true astigmatism that you would want to fix in such a patient after you take care of them. So when you're offering spectacle freedom, that astigmatism must be managed. So toric IOLs, we're so fortunate that we can, fix at least 0.75 diopters of total refractive astigmatism. And then, but truly it's going to be important that for less than 0.7 diopters, we don't leave any more than maybe 0.3 on the table at most. So we definitely should be considering some form of keratotomies, whether it's femto-AKs, even for a half diopter of against the rule. I would dare say if you've got a half diopter of against the rule and you're going to do a monofocal, I would consider using like a Bausch & Lomb monofocal, because Bausch & Lomb can fix, 0.8 diopters. And while that, technically speaking, that with the posterior cornea, you likely will, it will be a net, it'll take care of it altogether. But just know that against the rule astigmatism is, patients don't tolerate that. That leads to blur. And we know that, so important. So we've confirmed the quality using the Placido disc topography. We confirmed the quantity, the axis, the amount, with at least 2 devices. And this is where, for me, this is where the Lenstar shines. And my Lenstar shines because, as I mentioned before, Placido topographers, basically, they capture about at the 3 millimeter zone, and everything's interpolated to be, around there. But the Lenstar, I will show you, it captures very centrally between the 1.8 and the 2.3, and I will show you how many data points. So it's extremely accurate and close to the actual visual axis, to the center of the cornea. So the other components that are also important in considering astigmatism management, when I say refractive astigmatism, I'm not talking about what's in glasses, because we know that lens and such can affect that. But when I say refractive astigmatism, I'm talking about the total astigmatism within the eye because of what's coming from the anterior cornea plus the posterior cornea, and then the effect of effective lens position and IOL tilt, because all of this plays somewhat into it. What's so important to know is that actually the Barrett formula does account for all of this, and I'll go through a little bit of that. So the corneal power measurements can be done by keratometry with the Lenstar, and like I mentioned, the Lenstar keratometry reads much tighter towards the center of the cornea than topography. And it does so with 16 times 2 rings, spots times 2 rings at tighter zones than with the Placido discs of any topographer. And the topographer is a separate little attachment that goes with the keratometer, but then you've got both quality as well as quantity. So, and the topographer will also provide your quantity. So now you've got your 2 devices right within the Lenstar that it can provide you all that information. There, like I mentioned, it's going to be within the 1.65 and the 2.3 millimeter optical zones. And then there are 32 markers because there's going to be the 16 spots that are taken. So with that being said, that allows for, with the 4 different readings and then the 5 measurements that are done all within, less than 2 minutes, a total of a very high value of measurements. And so what it shows you is that particularly the IOL Master 500 is the more legacy version. Now there is the IOL Master 700, but if you are vertical or horizontal, like particularly with the IOL Master 500, you're going to be okay. But you can imagine if you are with only 6 spots on the IOL Master 500, these are many degrees apart. So if you have anything horizontal, you can't have a great, not horizontal, so oblique, you're not going to have very accurate measurements because it's interpolating data. It's not really measuring exactly where it is. Whereas the Lenstar, because I know and I trust, and it's just so darn accurate. It really does get the meridian so accurately every single time because it captures right so central, and then with so many data points within the central cornea. And that it obviously, as you know, it has that toric platform, which then takes all that information and it allows you to have that toric platform with the T-cone toric platform. It optimizes what you are able to do for the patient's eye. So these are just great examples. And the different maps that you get on the topography side. As we discussed, you've got your axial map, which does the actual perpendicular distance from the tangent, from the point of interest to the optical axis. This is slightly different from what you're going to see with the tangential map. But the reason I like this is because it really shows you the regularity of the astigmatism. So I always look to this for the quality. And then I look to the placido to make sure that the surface quality, that it was a good quality image. But the axial map is where I look for the quality of the astigmatism. The tangential curvature is defined by the best fit sphere to the point of interest of its neighboring points, but it takes away the actual, it does that, and it does it against the actual cornea, not against the visual axis. So by doing so, it's slightly different than the axial map, but it actually helps reduce the noise a little bit for somebody when you're trying to see, is that really irregular astigmatism, or is it because this patient has a larger angle kappa? So it's helpful in that realm when you look at somebody where it looks like they have irregular astigmatism, but it's really because they've got a larger angle kappa. So it's looking at it in that realm. Then there's the elevation map, which shows the difference in height or elevation of the cornea to a best fit sphere. And then it just has the different colors, just like topography in general. And so this is exactly what I'm talking about. So you've got your placido image on the upper left, your axial on the upper right, your tangential, which will highlight focal irregularities like keratoconus, but it also helps to neutralize what can happen from angle kappa or chord mu, and then your elevation map, which will, kind of like true topography, documents the local elevations and depressions. And so this kind of shows you different T-cone topography maps, but I specifically wanted to bring your attention to the top over here where I wanted to show you was, for example, the upper right image. You can see that in the upper right image, look at the axial versus the tangential map. Like if you look at the axial map, because of this patient's angle kappa, it looks almost like they've got some very irregular astigmatism with a lot more flattening. Let's say this is the right eye, in that 1 to 4 o'clock, a 1 to 3 o'clock quadrant. But if you compare that to the tangential map, because it's not relative to the visual axis, but versus relative to the entire corneal surface, you can see here that it actually is it neutralizes the effect of the actual visual axis. So I'll actually utilize that information a little bit more, particularly if I am assessing patients, for example, like LASIK evaluations. So the Lenstar T-cone, like I mentioned, it is combining the information from keratometry plus the topography. And we need to take advantage of these advanced toric calculators and IOL formulas. And it really does show that because we're so fortunate with the Barrett formulas, which takes into account the toric formula, the anterior corneal astigmatism, posterior corneal astigmatism, effective lens position, and because the results really do show, I've shown it with a paper, many others have demonstrated it, that we have such little residual refractive cylinder postoperatively. Like, for example, I have, 80% of eyes with a quarter diopters of residual refractive silt or less, and 98% of eyes in this study that I did prospectively. If you look at legacy calculators alone that only take into account the anterior cornea, it's only about 50% of eyes that have a half diopter or less. But if you did not look at tilt, it couldn't be this effective. So in personal correspondence with Barrett calculator, with Graham Barrett, he does say that his almost pseudo artificial intelligence, it definitely is taking into account IOL tilt in this formula. And so all of this is available within all the Lenstar information, as you know. You want to understand and match the best tool or technology to the patient. And then ultimately, you want to track your results and track the eyes of the IOLs. We want to utilize the various formulas and those that are housed within the Lenstar just to demonstrate the different types of capabilities. We kind of understand that axial length measurements, there's certain things that we take into account, right? Just so that we can understand. There's anterior chamber depth, there's corneal thickness, there's axial length, and there's certain machines that account for the AC depth from the front of the corneal surface to the front of the lens. Different formulas will account for lens thickness, and effective lens position is also accounted for by certain distances, and I'll show you that as well. With that being said, in the phakic eye, there are obviously various peaks with the cornea and the anterior to posterior lens, as well as the retinal thickness. And obviously, you want to see that to ensure that there isn't tilt, that these are, even height in thickness, and all of these can be adjusted for. But when we go to this composite algorithm, which is a page that is something that we can review as we get all the information per patient history. This allows me to also look at the actual center of the visual axis versus the center of the cornea. As I take this information, I also like to see sometimes if there are any outliers that I may or may not want to keep. But for example, like if I'm planning for a multifocal lens implant, okay, I'll look at someone where if I'm like, oh, wow, they have a pretty significant angle kappa. It looks like the XY looks pretty significantly different. Like, for example, this patient's visual axis is nasal to the Purkinje 1 image. So I'll put a little surgeon note in this right eye, align it a little slightly nasal to P1 in this patient, especially if this was for someone who had a more dense cataract, or I knew that this was a patient who was post-vitrectomized or something where I may block them and I can't have them actually, focus their eye at the end of the case. So these kind of notes will help me. I've had a patient look like this after surgery, and the patient's 20/20, But the referring OD is like, oh, the lens is decentered, must take him back to the OR. So then these are the times when I say, well, are they really decentered? Because they're complaining of glare, right? So is it really decentered? Or is it because the visual axis is off center, right? Off center to the center of the pupil. So the right eye, again, I'll then utilize the image that is captured from the Lenstar. And this is that image. So this image from the Lenstar, I know that my multifocal ring should look like this, that the multifocal ring may appear nasally decentered to align with the patient's visual axis. And I will send this image and I'll say, Dr. So-and-so, and if it's obviously different, then I can also then understand that. But it's actually looks funnier because not everyone is nasal. Some patients are temporal. So it's really a little bit more off-putting to your referring OD when it is more temporal and the patient comes in with that complaint. But when it does happen, it's going to happen because not everyone has that nasally displaced visual axis or optical center. So just so you know, these are the kind of things that are very helpful that additionally are just part of the image capabilities that you can utilize. And it's part of that Lenstar suite that, give it that extra oomph for that biometry beyond the biometric information. And so the variable formulas, right? There are various formulas. Obviously, my go-to are going to be utilizing the multivariable formulas. I like using the Olsen as well as the Barrett formulas. And you can tell they do account for the anterior chamber depth as well as the white to white. And they're looking for effective lens position. Essentially, it does account for it in different ways. And then the Olsen formula has ray tracing and it looks into like the lens thickness considerations, et cetera. And there are other formulas that are out there online and like the Kane, et cetera. But my go-to are going to be some of these formulas plus the Barrett Universal, as well as looking at the Hill RBF formula. And these are all going to be truly the most superior for my average axial lengths. Kind of a lot of them perform well, right? For my long eyes, my Barrett Universal outperforms, and it generally does outperform, the Wong Coke. My short eyes, honestly, it's a little bit of a toss-up. It just sort of depends. And then I always utilize the results of my first eye to help fudge and determine what I need to do on my second eye. The Holiday one actually helps me. The Hill RBF is great, as well as the Barrett Universal. It's okay in short eyes. And then, the RBF, it's different. It is more data driven with 5 different points and with data interpolation in order to get that formula. And it is independent of patient specific parameters. So these are the various formula calculations that are within the Lenstar 900. And the Barrett True-K, truly, it is absolutely incredible for obviously our post-refractive eyes. And we're very, very fortunate to have that and the ASCRS calculator there. So I'm going to quickly go through some cases in the next 5 minutes. And then for the last 10 minutes, I'd love to be able to answer any questions that do come up. And of course, if there are questions that we can't get to, then I will definitely give you my email address so that we can certainly communicate. So a 63-year-old patient, myopic LASIK, about 13 years ago. Patient was satisfied post LASIK. Vision was pretty good until recently, but as you can see here, the vision isn't that bad. She bats down, but she's one of those patients who's almost a 20/20 cataract, so she's coming in with pretty high expectations. You can see here, she may have a little bit of dryness on the right side more than the left, but well-centered beds, good ablation beds, and the actual higher order aberrations are low. So, we've got a bunch of different lenses that are available. The most important thing for me in these kind of patients is to consider, one, were they happy with their laser vision correction? Was their night vision okay after LASIK? How risk averse are they? If we don't hit their target, how risk averse are they to an enhancement procedure or even an IOL exchange? Those answers will ultimately help guide the decision of what kind of lens that we will proceed with. For me, I will start with the non-dominant eye first, especially if it is the right eye. The left eye in particular is the one, if it is the dominant eye, I feel like I'm golden to start with the non-dominant eye first, because the left eye is the one that cross the highway or across the road will be the one that sees that cross traffic. And so that's the eye that will see more of the glare. So if their right eye is the non-dominant eye, I feel like I have even a little extra wiggle room, because I may be able to get away with a presby correcting lens, even if they are somewhat nervous about the potential for positive dysphotopsias and night vision symptoms. But we'll make that ultimate decision. So we went with, actually in this patient, moving forward with an actual trifocal lens, PanOptics, and the patient did well. While we targeted for plano to -1/4, she ended up just a little bit +1/4, but had nice vision. And being actually +1/4 may have, helped with the dysphotopsia profile. The rings were not bothersome. But in this scenario, if the rings were a little bothersome, but she did not want to replicate those rings, I would have considered a Vivity lens. And I've definitely blended those two. If she was really unhappy, I would have either said, let's stop, we can exchange that first eye, but let it settle. Or if she wanted to proceed with the second eye surgery, or just wanted social reading and was okay, I would have even considered just a monofocal toric and proceeded. And she would then know that she would have some reading, both eyes would have distance vision, but she would not have nearly the amount of the dysphotopsias, because it would be, mitigated by the second eye. So with that being said, let's look at case number 2. 68-year-old patient, wore contact lenses, but stopped 6 months ago because of increasing intolerance. She's 5'9", retired, works on the computer, but for leisure only. You can see here, she does have some evaporative disease. She does have early cataracts, and the back of her eyes are normal. But very obvious here, this patient, look at that right eye. I mean, you can compare that there definitely is a Placido image. Myers are not normal, axial map quality, irregular astigmatism, definitely suggestive of something going on. We know there was quick tear film breakup, but look how variable, especially the right eye, these K values are between the devices. This inter-device variability demonstrates to you that even if the average K value, let's say that the average K value was similar, but the inter-device variability in the amount of astigmatism or the meridian, any of those, that shows you that there's evaporative dry eye. And that's very important. And you can see it with the meibographies. So this is after taking care of, some of that treatment. What a huge difference. And you can see what a major difference there is between the delta K, so the amount of astigmatism, much more similar, as well as the average astigmatism, and the meridian, all much more similar. But in this patient, definitely not going to do a diffractive presbyopia correcting lens, but she wants freedom. So now is when we tried a mild mini monovision, because now with the enhanced monofocal lenses, I know I can get away with a -1.25, -150 if they're only looking for some computer freedom, knowing that they would need reading glasses, but I don't want to try to put them in full monovision if they've never had it. But she did well. And because she did well, this is a patient where, while I would never do a presbyopia correcting lens, this is where we went with enhanced monofocal with that goal. Now, she did great. She was very fortunate. Ended up only a -50 though, but she's 20/20 in J3. The first eye results though became, they were surprise. Steep Ks, her K values were, where are we? She was, actually her anterior corneal power was only 42, 47. So no, not steep. She's a little bit, no, she's not too short in axial length. Oh, she's a little flat, 42, 47, a little bit flat, but a little bit of a surprise outcome. But I use that information to adjust for my second eye. So instead of that 1950, I went a little bit stronger. So going for, first minus, just to help with this patient. So here we are. The final pearl is that we have to accept that sometimes we do everything. We have to be kind to ourselves. Patients may be unhappy. We do everything in refractive cataract surgery to do what we can, but dissatisfied patients are going to be inevitable. And in this stage of the game, I feel that that's just kind of what's around us. But be kind to ourselves, find the root cause, address them as professionally as possible. I hope that these pearls will help you to help mitigate and prevent some of those causes. And please email me if there was anything that I couldn't get to or went too quickly. And I know we have about 7 to 10 minutes, and I'd be happy to answer any questions.
Dr. Yu, thank you so much. It was a fascinating webinar. I really enjoyed it, and we do have quite a few questions lined up, so let's see what we can get to. Okay, first question is, we have a resident. What advice can you give me as a resident to master formula choice and feel confident, and how did you learn this?
Oh, excellent question. See, we're so lucky now because the formulas have gotten so much better over the last 5 to 10 years. I will tell you, beyond the K values of steep corneas, like over 46 diopters, these are even normalized, or really flat corneas that are like abnormally flat, less than 42 diopters. If you've got an average axial length between 23 to 25 millimeters or 22 to 25 millimeters, all formulas perform pretty well, but Barrett Universal, you're going to do great. 25 millimeters and over, Barrett Universal, you're going to do great, honestly. And those are already embedded, right? In your Lenstar. You can obviously find it online, but these are in your biometers. For your short eyes, that's going to be a little bit tricky, like I mentioned. But your fourth generation, your modern formulas are going to be the way to go. But truly, the Hill RBF is another one that you can check with. But I will tell you that going these routes, and then obviously your post-refractive eyes, we're so lucky that, again, Barrett True K and the Barrett Toric, because it accounts for everything I just mentioned with your anterior and your posterior corneal astigmatism, as well as effective lens position and the other components of refractive astigmatism, it's going to be your go-to. I can send you a snapshot from Mitch Weichert, who's kind of one of the leading gurus on some of the more modern formulas like the Kane, and there's some other ones that are really complex and you have to pay for some of these formulas that are just not readily available. I can send you that snapshot of what he uses, but these mainstream ones are my go-to, and my residual prediction error of a half diopter is 94%. So I can get you that information.
About what percentage of your patients do present with trigia?
Oh, pterygia?
Trigia, thank
Yeah.
you.
Oh,
That's
no, sure. So pterygia, I'm going to be honest now, I live in Virginia Beach area, so I get a pretty good amount of them. But I will say, whereas when I lived in Houston, I did a whole lot more pterygia surgery, like sometimes upwards of 5 a week. I only do maybe 3 a month now. But once I do pterygia surgery, I wait a full 6 weeks before I'll proceed with cataract surgery. And I do, roughly 15 to 1,800 cataract surgeries a year, just depending on the year. So I don't see a whole lot of pterygia patients for the sake of pterygia, because my practice over the course of the last 11 years here has kind of become a little bit more refined from very cornea heavy to more a combination of cornea and cataracts.
Okay, that actually leads nicely into our next question, which is, how much of a challenge are dense cataracts for your practice, and how do you, how do you manage that?
Yeah, dense cataracts, if you know that they're dense and you're going in prepared, it depends, because dense cataracts can be challenging in different ways. If it's a white dense cataract, the hardest part is the rhexis, right? And decompression to make sure that you have a great capsulotomy sometimes is the hardest part, because the capsule, after the capsulotomy, the cataract itself is usually brittle, and it may not be the hardest, right? It might just be a slurp, especially if it's a young cataract, a young patient, right? So then you've got your brunescent ones. If it's super brunescent, they may need an MICS procedure. But if it's brunescent, you may consider something like a MyLoop. A MyLoop has really been extremely helpful. If there are 4+ brunescent lens, like plus, like where it almost looks that sheen of black or mahogany, femtosecond laser is not going to touch it. I mean, or not really. Like early 4+, femtosecond's beautiful because it softens it up. But when it's so dense, it doesn't go deep enough because it's so opaque. And that's where getting that fibrous plaque, leathery plaque with the MyLoop nitinol lasso. And if you can, I know that Zeiss actually helps with residents and making certain that, that MyLoop device is part of training. So getting exposure to that is excellent, so that you can be more proficient at those super dense lenses. And that saved me.
Okay, excellent. And how about for measuring, for getting through the dense cataracts for measurements in biometry? What is your tip there?
Oh, I'm so sorry about that. I'm going to say, except for PSC occasionally, Lenstar does a beautiful job. Sometimes fixation is hard for the patient because their eye drifts. And in those situations, I have to do ultrasound biometry for those patients. But beyond that, the Lenstar it just kind of takes care of most things.
Okay, thank you so much. Let's just do one more question. I don't want to run out of time here, and thank you so much for your time, Dr. Yu. Question is, this is a good one. What lens types are you kind of currently most excited about now, either that are coming on the market or on the market? What are some of your go-tos right now?
Sure. I will say, and I've already mentioned this, I think we're so fortunate for having an enhanced monofocal. I think that the iHands has really helped me not have the conversations of, oh, you won't be able to see yourself in the mirror. It's a practice builder, which has been very nice because patients are just happier. It is a little bit more expensive as a monofocal. So it's my go-to with toric IOLs. I will say for presbyopia correcting lenses, especially for monovision, those who are successful in monovision, super, super looking forward to having the small aperture AcuFocus lens. And then as I get comfortable with that, I know that I would like to be able to start utilizing it in certain irregular corneas, post-refractive eyes, because they can get at least in the dominant eye that monofocal in that eye too. And, ultimately, I would like to really see a true accommodating lens on the market, like the LensGen. So all of these, I think, are, that spectrum. We're lucky for the type of multifocals that we have today because they are just getting better and better in quality. That's not what I'm saying, but it'll be very nice. And it is nice that our portfolio of different options are going to grow.
Oh, Dr. Yu, thank you so much. We have some more questions that we'll follow up on email, just given time, but we have a bunch of comments. Just thank you very much. Great conference, so informative. They're very happy that you shared your email with them. So expect some correspondence. And we very much appreciate it. So Dr. Yu, thank you so much. It was wonderful.